to welcome you on behalf of UCSF Global Health Economics Consortium, and I hope that today you get your geek on. That's the Ghecon thing, yeah.
What we've generated is more conundrums than answers at this point, so helping us develop hypotheses about how to go forward. So in this first phase of research, we found essentially that male obesity and female smoking are both unusually low in international comparisons related to something like the US, and they can statistically account for the Costa Rican mortality advantage at older ages. So we can ask, well, why do the low SES in Costa Rica have lower cardiovascular risk? Well, we can talk about healthcare access being good, but we know that healthcare access doesn't affect many of the risk factors underlying prevalence, and it certainly didn't help with hypertension. And so people turn again to this upstream social structure and safety net.
But we found that overall, the prevalence of sugar-sweetened beverage consumption declined by 21% in Berkeley, and it increased slightly by 4% in San Francisco and Oakland, the comparison cities. And if we look at the rest of the beverages that we asked about, we can see that there was actually a significant decline, a significant difference in the direction of trend for regular soda consumption, sports drinks, and water. Now, there's a huge increase in water consumption in Berkeley of 63%.
So the tax, the SSB tax in Mexico, very similar to the one implemented in Berkeley. In terms of sales, this is data from the industry. And what we see here is, again, this is sales, what we actually observed, and model what would have happened without the tax and what would have happened with the tax. And we also see significant reduction in sales of SSBs. In particular, in 2014, a reduction of 6%, which is consistent with found in purchases using different data. 8% by 2015, 11 by 16, and increases over the same period of time of 5% in terms of bottled water.
In conclusion, the MNS conditions have a massive disease burden, and mostly that's due to disability, although, as I said, we may be underestimating the mortality burden somewhat. There are efficient and affordable interventions for most MNS conditions. Stigma is high and awareness is low concerning treatment options. Care capacity to deliver quality treatment is limited, especially in primary care settings. By the way, dementia is definitely prevented by the same kinds of interventions that will prevent cardiovascular disease and so on. So there's a synergy there. But in terms of interventions specifically for dementia, not much yet. And likewise for some addictions, not many options. In my opinion, as a little bit new to the MNS area, there's ample justification to expand MNS funding and capacity.
Just to sort of give you a little bit more on these different models, and there are lots of details that we could get into that I'm not going to in terms of the differences. They are looking at long-term health impacts. They do give us economic impacts as well. Of course, that's what they're for. But different kinds of economic impacts. They have different diseases and risk factors in them. But basically what countries are after is we want to know what the costs and benefits are of better control and management of NCDs. And they also do want to use it for planning. They do want to use it for deciding which services come first and how to scale up and how to deliver to certain communities, etc. So we have a lot of information that we need to get by applying this in context. And then we need to improve what we're doing so that we can continue to address this problem in a reasonable way with good data and efficient use of the limited resources that there are.
I'd like to say that RCTs are the gold standard. And a key point for you guys is that evaluations really can't have external validity without internal validity. And this applies especially, I think, to the modelers in the room, that the inputs into your models, it really helps to have something that's a well-identified parameter. And I think using RCTs is a really great way. Having experimentally identified parameters is a great way to do that. They're easy to understand, and they can really reveal important insights about mechanisms, in particular, in our case, about peer support, peer pressure, the bonus, deposits, etc.
In terms of IV analyses themselves, these and other quasi-experimental methods that I didn't discuss today can overcome the challenges in confounding that in terms of situations where randomization just is not possible. And where possible, we can do multiple of these different kinds of methods to try to triangulate on the correct answer to the effects of socioeconomic factors on health disparities. And in a time when we have a lot of discussions out there about inequality, this type of research can inform multi-sectoral policy interventions.
At this stage of this project, the weight of the evidence supports a link between trade liberalization and growing waistlines. While this seems to be the project at this point looked at a lot of the obesity and overweight, there's also, especially on low and middle income countries, the other side of the spectrum. And in addition to rising rates of obesity, there's also a parallel decline in rates of stunting and malnutrition.
So to summarize, evidence synthesis plays a major role in cost effectiveness modeling or decision analytic modeling. We want to have proper estimates for the baseline model, absolute effect with the reference treatment. We also want to use proper estimates for the relative treatment effect versus the reference. And the relative treatment effects versus the reference, we like to use that to base that on randomized controlled trials, and we can use network meta-analysis techniques. And the key thing is, in all these kind of economic models, if we need to extrapolate, make sure that you really test the assumptions of your model, in particular proportional hazards, because it can result in dramatically biased estimates.
So RA drug spending is among the top spending category in specialty drugs. We've actually reached a point where the cost of a biologic is surpassing the median income of people. So my conclusions, specialty RA drug prices are rising sharply each year despite competition. High prices are being passed to patients. And I think biosimilars will eventually reduce costs, but they're unlikely to produce the substantial savings that we see in the generic market for small molecule drugs.
What's been absent from this entire framework, though, was any sense of cost or cost effectiveness. They're always been aimed at optimizing clinical care and outcomes and not paying any attention to the economic part. And these were the proposed level of value criteria. So a high value, better outcomes at lower cost, or an incremental cost effectiveness ratio of less than $50,000 per quality gain. Intermediate, 50 to 150, and low value above 150. So let me just wrap up by saying that I think that these clinical guidelines are highly regarded and very helpful to doctors. They're used in practices. They're actually used to even set performance measures and so on. We are trying to get value statements into these guidelines, but it's very challenging still. We don't have good evidence to back up all the recommendations that are out there, and we need high quality evidence that everybody can trust before we can go ahead and put this in.
The second panel has been recently published their findings. So as Doug mentioned, I co-chaired this panel with Peter Newman at Tufts. We actually have 4 chapters that are brand new, one focusing specifically on the reference case. Our recommendation actually for the reference case is changing the original panel's recommendations, and we now actually are requiring or asking that all studies represent a reference case based on 2 different perspectives. One that we're calling the healthcare or the health sector perspective, and then a second reference case based on the societal perspective.
But part of the rationale for a reference case is that I can compare my analysis to yours, and maybe we can compare an analysis done now to one done a few years ago. But the changes that we made in the reference case are substantial enough that we recognize that it really was going to impact the ability of comparability over time looking backwards. The impact inventory really makes very explicit that you might have situations in which there are spillover effects to other healthcare sectors, education, criminal justice, etc. And that's very rarely included in cost-effectiveness analyses.
Then how to integrate cost-effectiveness into broader decision-making frameworks?
What is integrated care? And, WHO has a very long and complicated definition of this. The simpler definition that I learned in my first year at Kaiser was we aim to provide the right care at the right place at the right time. What do we know about integrated care in low and middle income countries? And also, can we categorize this evidence based on the triple aim? The conclusions are integrated care examples are really in their infancy, but policymakers in countries are interested. And finally, I think this is our vision and our challenge for the future, which is a complete transformation of healthcare.
So what is my prediction for Medicaid expansion? I think that they are probably going to have to keep it because it's going to be hard to get rid of. But it will probably be rejigged so that states will have more flexibility on using market-based solutions to Medicaid expansion. What does that mean? It means we're looking at a partial repeal. And that is probably worse than repeal and replace. Finally, I told you that I didn't think this is a time where we can sit back and relax. We can do very good work, but this is the time where you have to engage yourself in advocacy. There are lots of different options. You pick one. It doesn't have to be perfect.
So in the context of global health, there are at least 3 implications of utilitarianism that fall directly out of these principles. The first is really a restatement of what I just said, that within healthcare provision, we want to allocate resources in a way that's consistent with maximizing benefit. Global health and public health, the word global in global health and public in public health pertains to large populations and thus lends itself to the more abstract modes of reasoning that are consistent with utilitarian calculations. And therefore, utilitarian calculations and where cost effectiveness leads is the right place to start in thinking about resource allocation.